All right, so I think we're going to go ahead and get started. Dr. Guy has a lot to share. And so for those of you that don't know, Dr. Guy is the lead psychiatrist over at Perspectives, but he's also someone that has worked at Easter Seals. I'm not sure if he's still doing that. I heard that the bio that I had was maybe a little bit outdated, but he is a phenomenal human being as well as a phenomenal psychiatrist. I have a lot of clients that see him and have nothing but good things to say about not only the treatment that they receive, but the education that they receive as well. So they are informed clients. And so I just like to say thank you, Dr. Guy, for just being such a fabulous psychiatrist and clinician and educator. And so today he is going to enlighten us. There will be room for questions and answers at some point. And also Lindy Bostic is going to be coming and talking today about the TMS treatment. And so without further ado, let's give a warm welcome, maybe a high five electronically, to Dr. William Guy. Thank you so much. And everyone, if you can mute yourself, that would be wonderful.
Okay, the subject matter for today's presentation is mental illness and COVID-19. This is a pretty depressing topic to discuss, actually. This is not one of those happy topics where we have wonderful treatments and everybody turns out just fine. What you're going to learn in today's presentation is that COVID is quite a bit more serious than getting the flu. There are short-term and long-term consequences that most definitely affect psychiatric illness, and we're going to be talking about those today. We're going to start out by talking about the direct effect of the virus on the central nervous system and talk about how it contributes to mental illness, things like depression, anxiety, and psychotic illnesses and so forth. So there is a direct relationship between this virus. This virus does penetrate the central nervous system. It digs into your brain and causes brain inflammation. So we're going to be discussing that. Those are direct effects on psychiatric health. And then we're going to talk about the more indirect things. We're going to talk about the indirect effects of COVID-related morbidity and mortality and how that affects grief and so forth. Also talk about the COVID-related societal changes and how those are impacting people. Then briefly toward the end, we're going to discuss other factors such as COVID and eating disorders, COVID and substance abuse, COVID and suicide. Okay, this is not meant to be comprehensive, but this is, at the time of this presentation, it was available for CME credits, and so we are hopefully going to be inclusive enough so that you get some education out of this. Okay, so let's get started. All right. Now, there are a lot of review articles out there talking about the psychological and psychiatric and neurological effects of COVID-19 on the population. There are quite a few of them, and what they all agree on is that there are now more people in psychiatric distress than there were before COVID. Okay, from this study that we're looking at right here, last year, the number of individuals, the percentage of the population, at least in England, that was psychologically distressed at any one time was about 19%. In the new COVID world, that's closer to 30%, 27.3%. So yeah, a lot more people are experiencing emotional distress, and a lot more people are falling into psychiatric illness category, people that didn't before COVID. And it's higher for women than for men, okay? And it's also, the younger you are, the higher the symptoms. We're going to talk about that later. So even though younger people are less susceptible to death and morbidity from this virus, they are much more susceptible to the changes to our society, having a negative impact on their psychological health, okay? They are definitely psychologically way more impacted than any other group. You're looking at that, 24 and under group. It's not good news for those populations. So let's start with the direct effects of the virus on the mood. And I think, when I was asked to do this type of program, I had to do a lot of work. I thought, I've talked about depression so many times and done so many programs on it. I thought I was just going to mix together a conglomerate of talks I previously gave and kind of do a little souffle and produce a new talk based on talks that I've already done. So this was going to be a no-brainer. Well, it wasn't a no-brainer. There's all kinds of information out there that if I'm going to do a talk on depression and COVID, then I need to research it. And so I had to research it. And I learned a lot about this virus that I didn't know before. I thought I knew everything there was to know that was of significant, and boy, was I wrong. Okay, I learned a ton of stuff. And I suspect that most people who are going to watch this video are going to be impressed with how much information they didn't know about COVID-19.
As you know, after I got COVID in the last week of October, I had mild respiratory symptoms for about a week. Then I fell into a depression for almost a month. I had no energy at all. All I wanted to do was sleep all day. I had no motivation or anything.
Okay, in this particular patient, this is very common. One of the things as clinicians that we need to be watching out for is when you get a patient who did not have a history of serious psychological problems before. No long history of chronic depression, chronic anxiety, post-traumatic stress, none of that. And suddenly they appear and they are severely depressed. I mean, they can't get out of bed. They lost pleasure for everything, severe anhedonia, severe fatigue, and they come off and they say, you know what, I don't enjoy anything or anybody. I am so depressed. These individuals, please have a high suspicion for COVID-19. There's quite a high percentage, almost 20% of patients with COVID-19 don't have symptoms. Okay? Now, what you're going to find is that people with the chronic fatigue have usually had some symptoms earlier on, but you can't always count on that. They're not always aware of them, especially if they're mild symptoms. Even people with mild COVID symptoms can have chronic fatigue after the infection abates. I myself was one of those people. I was doing mitigation strategies when I did contract COVID from a patient. And even though my symptoms were very mild, they lasted only 4 days, and it was nothing. I mean, seriously, I've had colds way worse than that, okay? But for a month following my COVID, I had chronic fatigue syndrome. It was serious. I mean, I was seeing patients from my house, and so I would see somebody take a nap, see somebody else take a nap. And the first week, it was like every other patient. And then second week, it was only maybe like 4 naps a day. And then third week, 3 naps a day. And so by the time we get to the 30 days, I am no longer taking naps every day. But that's what it was like. It was chronic fatigue. And so when this is something that you very commonly see with COVID infection. So please, as clinicians, keep that in mind. These people are assuming that they're depressed about their lives, when in fact, mostly what they're feeling is COVID. They're feeling the consequences of having a COVID infection. Doesn't mean they're currently going to be having COVID infection. The COVID infection is probably gone. But after the infection, this is when you're left with the chronic fatigue. And I'm going to talk specifically about that later on here, okay? When most people think about the medical consequences of COVID-19, mostly they're thinking about COVID pneumonia, okay, because we know that can kill you. We know that's very serious. We know that's why people end up on respirators. But what many people in the general public, and even some clinicians, don't know is that this virus is very versatile. It is not just a respiratory virus. It has, with those spike proteins on the capsid of that virus, that's like a skeleton key, man. And it can gain entry into multiple types of cells in your body. So yeah, it enters the type 2 pneumocytes in your lungs. Sure does. It also enters your brain cells, your neurons. It goes very commonly through the cribriform plate into the olfactory bulb. And that's why a lot of times you're going to lose your taste of smell and taste, because you've got inflammation of cranial nerve 1. And when that thing is inflamed, it kind of goes offline. And so you can't taste or smell things. And unfortunately, in some individuals, There's so much inflammation at this site that they permanently lose taste and smell. It causes scarring of cranial nerve 1. And I don't know. This is so new that we don't know if in the future that's ever going to come back. I hope it does for your sake. It's kind of scary finding yourself in a situation where you may never taste food again. You may never smell anything again. That's not a good sign, okay? It's not a good sign at all. So there's that. It goes into the brain cells. It goes into your blood cells. We're going to talk about that lastly, and that's where a lot of this fatigue comes from. That's where the hypercoagulability comes from. It makes your blood coagulate really quick and really easily, forming clots. And it also gets into your kidneys. Okay, so those are some of the big guys. Those are some of the really big guns that this virus wields to harm you. Now, how does it compare to Spanish flu? Spanish flu was way worse. Spanish flu, if you contracted Spanish flu at 9 in the morning, you could be dead by 9 p.m. I mean, it was horrible. It was Ebola on steroids. Spanish flu was way worse. We've had polio. We've had lots of microorganisms, lots of infections throughout history that are far worse than COVID in terms of their ability to result in debility and death. However, it's hard to compete with this drug with regard to how infectious it is. It's very contagious. Spanish flu was too. It was, okay. But this is, of the current viruses known to man on Earth right now that are bad for us, this is one of the more contagious viruses. It's pretty easy to get. I got it. I was in the same office as a young woman that had it. She didn't even know she had it, okay? She was sitting 10 feet away from me, just talking to each other. It was back before masks were mandatory, right? We didn't even know we were supposed to wear masks back in those days. And that's how I got it, okay? Just being in the same room, breathing the same air, okay? So really, really contagious. So people who've had serious COVID infections, they've been found to have significant neurological sequelae as well as psychiatric problems. All right, and now this paper right here was done in England. It was one of the earlier studies that were done looking at hospitalized COVID-19 patients, and it basically, of those, I think there was like 119 people in the study. 153. Okay, so of these 153 very sick hospitalized COVID patients, they went through and they said, okay, what percentage have neurologic or psychiatric problems? It was pretty high. 62% with cerebrovascular events. Okay, I think these are all people this is a subset of people that had something neurologic or psychiatric. So, okay, just want to make that clear, okay? But when they had something, very high percent of 62% cerebrovascular event. So that's like a TIA or a stroke. Why? Keep in mind, COVID causes clotting. COVID, clotting, both start with C, okay? So remember that. That's why when you hear about people having strokes, but they had COVID and they list COVID as the cause of death, that's not necessarily cheating. The COVID accelerates inflammatory states and coagulation, okay? So you speed up clots and heart attacks and DVTs and things like that. It actually does that. It's known to do that. 12% had intracerebral hemorrhages. 1% had vasculitis, where there was an inflammatory response for the blood vessels themselves. 13% cerebrovascular events. 18% with encephalitis, where the body attacked the entire brain. There was so much COVID infection of the brain that it generated an autoimmune reaction where the body attacked the brain. Okay, it's pretty serious stuff. 23% with encephalopathy, such as psychosis or hearing voices, being delusional. Okay, these are all things that happened with acute COVID infection. Neurocognitive disorder in terms of dementing process and the acceleration of dementing processes. So the mentation becomes much worse in the face of COVID infection. Then you have peripheral nervous problems such as Guillain-Barré and other peripheral nervous system problems. So it affects you neurologically as well as psychologically. All right. Now, it does appear to be age-related. The older you are, the greater your risk of neuropsychiatric complications and cerebrovascular complications. And when we're talking cerebrovascular, you're talking about clotting of those blood vessels, inflammation of those blood vessels, increased risk of stroke. Okay, and notice that as adults in the 51 to 60 range, you're much higher risk for neuropsychiatric problems. So it's like depression, anxiety, delirium, that sort of thing. So about 25%. And when you get to be 60, the cerebrovascular events start to go up pretty significantly. Only around 10% between 51 and 60. Once you get to be 70, it jumps closer to 20. And the ages between 71 and 80, wow, like a third of these patients experience some type of cerebrovascular or neuropsychiatric event. So age plays a significant role in susceptibility to neurological consequences and psychiatric consequences with COVID. So pretty big deal. Now, one of the direct effects of moderate to severe COVID-19 infection, even mild infection, is that chronic fatigue. I had mild symptoms. Many people with mild symptoms end up with like a month of chronic fatigue syndrome. A month. Okay? Now, what if you have more than mild? Because mine was mild, man. I mean, we're talking only 4 days of upper respiratory tract symptoms. 4 days, and it was gone. But then I had a month of chronic fatigue. For people with moderate to severe corona infection, they're looking at a minimum 2 months. Minimum 2 months. And there are people that had COVID way back in March. They still have chronic fatigue syndrome. Okay? So its ability to cause this long-term fatigue is really high. And the more serious your COVID infection, the more serious your long-lasting fatigue later. Now, why is that? Why is that? Well, in terms of the brain, in terms of what it does to your brain, I mentioned earlier that the spike proteins on the coronavirus act like a skeleton key, allowing it to get into many cell types. And I mentioned the olfactory bulb at the top of your nose there. That's cranial nerve 1. It goes right into your brain. And so it can literally crawl, the virus crawls into your brain. And once it gets inside your brain, it generates an inflammatory response. So the white blood cells of the brain are called the microglial cells. And so what happens is the microglial cells, they start attacking the brain cells that have been infected with COVID. And that causes delirium. That causes anxiety. It causes you to sometimes not be in touch with reality and develop delusions. It can cause hallucinations. It can cause you to have, your consciousness to be affected, where you fall in and out of consciousness. I mean, it's pretty bad, dude. Okay, so yeah, that's not good. And ultimately, it can lead to neurodegeneration if it's severe. It can cause demyelinating diseases. If you have a pre-existing neurologic condition, that level of inflammation can make it worse very easily. Okay? And so that's very stressful. And this is on top of other stressors like losing your job, having the kids home and being in a confined space with family members that you're not used to spending time with. Okay, so this is on top of that stress. All right, as I mentioned, it's those spike proteins that allow it access into the neurons, okay, because there are ACE2 receptors on those brain cells, and that's how the COVID-19 enters these cells. That's how it invades your central nervous system, okay? And then ultimately, once it's in there, it generates an immune-mediated central nervous system damaging process. It causes a neurodegenerative effect. Now, if it's mild, it can be completely reversible. But if it's not mild, you can be left with long-term side effects. Okay? And so what is the consequence of inflammation of your brain cells? Depression, bipolar disorder, post-traumatic stress disorder. Mostly what this means is that individuals who have these conditions are at very high risk for having worsening symptoms. Could it give you symptoms like that? Oh, absolutely. It can actually give you symptoms that mirror these diseases like bipolar, post-traumatic stress, psychosis, obsessive-compulsive disorder, epilepsy, and Alzheimer's. So when you have brain inflammation, all those psychiatric conditions are on the table. So in somebody that has a pretty recent history of COVID infection, or even a remote history of COVID infection, if the psychiatric symptoms showed up after the infection, keep that in mind. Now, there are other organs that it attacks, and I mentioned these briefly. One of those other organs that those spike proteins can use to get inside of are your renal cells, your kidney cells. all right? And once inside the kidney cells, it kind of does what it does for the brain cells. It causes these cells to become under attack. Your immune cells recognize that these kidney cells are infected, and now they start to attack those kidney cells. Now, this is bad news for people at risk for kidney disease. What if you have end-stage renal disease, or you're already in renal failure? Then you just procured an infection that causes worsening renal damage. What if you have diabetes? Diabetes is already toxic for your kidneys, okay? Diabetes is very hard on your kidneys. And so you already have a disease that hurts your kidneys, and now you get COVID-19. Well, that's going to push it even further. And so you can take people with just getting by kidney function, and now they need dialysis. And quite a few individuals who had diabetes are now on dialysis, even though the COVID infection is way in the rearview mirror. I mean, they're done with COVID. It's been over for months. They're on dialysis for the rest of their life because of the damage that this virus did to their kidneys. Okay? So when you lose kidney, what do the kidneys do? The kidneys filter your blood of all kinds of toxic substances. Many of these substances cross the blood-brain barrier, and if they're not filtered out, they interfere with brain function, resulting in psychiatric problems, resulting in neurological problems, okay? And when somebody goes on dialysis, one of the things that you learn in psychiatric training or psychological training is that it's very common for dialysis patients to be on SSRIs, to be on antidepressants, because it's depressing. It kind of goes with the territory. You're on dialysis, here's an antidepressant. Why? Because dialysis isn't perfect when it comes to filtering your blood. It's not nearly as good as actual kidneys. And so your blood is a little dirty all the time. Well, some of these dirty substances that are normally filtered crawl into your brain. They go right through the blood-brain barrier, and they make you feel funky. They make you feel bad. Okay? So when you get COVID, and let's say before you didn't need dialysis and your kidneys were barely functioning, but they functioned well enough. Now, with COVID infection, they're not functioning well enough anymore, and those substances are crawling into your brain, and now we have another mechanism by which your depression gets worse. Okay? So, the effects on the central nervous system: neuroinflammation, and if bad enough, it can cause neurodegeneration and even demyelination. If you have an autoimmune disorder like multiple sclerosis, guess what? COVID-19 increases inflammation throughout the central nervous system, and autoimmune attack is inflammation. So you make it worse by introducing this horrible virus. It disrupts the blood-brain barrier, and so more chemicals that normally wouldn't crawl into your brain are now able to do that. And so you've got your kidneys messing up, resulting in more chemicals that crawl into your brain and cause funky mood. And then you have the blood-brain barrier integrity being disrupted by that inflammation. So even more bad things are able to whack you in the head. And so it's really hard. It's really, really hard to have a good mood with COVID infection. Okay? Now, I use this slide here just to let you know that this is not a comprehensive presentation on all of the neurologic problems that can be exacerbated by COVID. So just take a look. You got Parkinson's, seizures, stroke, Guillain-Barré, multiple sclerosis, Alzheimer's. So there you go. When you introduce a critter that can generate really strong inflammatory responses in your brain, you can worsen all of these things. Okay? All right. Now, it's not unusual for people to have fatigue during the acute stage of a viral infection, like influenza. Okay, with COVID, as I mentioned, that fatigue, even after the virus is gone, you can have fatigue for a month if it's mild, or what if it's not mild? 2 months to months, to months and months and months. So fatigue. Persistent fatigue is not unusual with COVID. And when people have COVID-related fatigue for 2 months or more, we call that long COVID. Long COVID. Even though the virus itself may be gone, you test them and they're negative for COVID. They had COVID months ago, but they still have the chronic fatigue. Okay? So why is that? Why does COVID cause chronic fatigue? Well, one of the reasons that you can have chronic fatigue is the inflammation that was generated by COVID. It takes a long time for that inflammation to go back down to normal. Inflammation causes fatigue. It does. Okay, so there is that. But there's something more. It has to do with the effect of COVID on blood. Okay, specifically iron processing. Iron processing. COVID causes iron dysmetabolism. Iron dysmetabolism. Now, before I talk about that, one thing I should mention too, though, is that COVID also, when it crawls into your blood cells, and it can cause hemolysis of your red blood cells, so that the number of red blood cells that you're floating around with is reduced, and that can cause some anemia there. But it's actually more serious than that. Iron metabolism is very, very much attenuated with COVID-19. What I mean by that is this. Okay, there is a spike. Remember those spike proteins that I told you about on the COVID-19 capsid? All right, those spike proteins resemble a molecule called hepcidin. Hepcidin is the master regulator of iron metabolism. It interacts with ferroportin to favor iron entrance inside the cells. Okay? And so what happens is that because this capsid protein, this glycoprotein looks like hepcidin, it functions like hepcidin, and you flood the red blood cell. Okay, when you do that, you cause all kinds of problems. It causes a hemoglobinopathy and iron dysmetabolism. Ultimately, what ends up happening is that the iron that is supposed to go in the middle of the hemoglobin doesn't get there. And so you got hemoglobin without that iron, and you also have so much ferritin inside the cell that the cell explodes, it ruptures, and that's one of the mechanisms by which you end up with this lysis of the red blood cells, and so you lose red blood cells. So you get iron deficiency anemia, and you get regular anemia with this. 2 months after COVID-19 onset, 30% of patients still have iron dysmetabolism. Okay? Now, why is that important? Well, early on, this was an important thing to know because we didn't know that about COVID. And so when people were in the hospital having difficulty breathing, we put them on respirators. And traditional labs didn't really show us that their blood was in that much trouble. We didn't know what was going on with iron metabolism. So we expected that, well, they're not getting, their oxygen's dropping, but it's dropping because of COVID pneumonia, so put them on a respirator. What we didn't know was that their blood was compromised. The hemoglobin's ability to carry oxygen was greatly attenuated. It was reduced substantially because of this iron dysmetabolism. And so as a result, it's like they lost half their blood volume or more. So you can get plenty of air, you can get plenty of oxygen, but if you don't have enough blood, enough hemoglobin to carry that oxygen to your tissues, then all of your organs are starving for oxygen. If you don't have oxygen, you don't have energy. You need oxygen in order to generate energy, in order to have electricity in your cells. You absolutely need oxygen. And normal oxygenation is, if you do a pulse ox, you want to see that number at 90% and above. So people were dropping below 90, and they put them on a respirator hoping it would work, but unfortunately, they were missing so much blood that the extra oxygen did no good, and they died. And so we've learned since then, and so people have a much greater likelihood of surviving because we learned, hey, how about a transfusion? And the transfusion could help, okay? Because that's what they needed. They needed blood that had hemoglobin, okay? So it can carry some oxygen for them. So as a result of COVID-related iron dysregulation, patient ends up with iron deficiency anemia, a coagulopathy. Remember, we talked about that earlier. That's where the increased risk of strokes come in, and increased inflammation. So this is really bad news. It's terrible news because it should make you concerned. If you haven't had COVID yet, you're probably thinking, man, if I get COVID, I don't want the bad kind. I don't want moderate to severe because, gee, that's going to affect my life in big ways. If I am constantly tired, have no energy, how am I supposed to work? How am I supposed to interact with my family if I'm in bed all day? Okay? So, yeah, you're probably worrying about that, and you should. You should. Okay? So, what can you do to mitigate the risk of the more serious COVID infection? There are some things you can do, and this isn't comprehensive. I wanted to throw some hope in this talk because I don't just want this to be negative. Oh, you learn about pathology, but nothing about how to address it. So I want to include a little bit on things you can do to reduce the risk of more severe COVID infection. Number one, survive a mild COVID-19 infection. One question that's been on everybody's mind is, if I get COVID, what is the chance that I can get it again? I've seen some news presentations that have made it sound as if it doesn't matter if you've had it, you can always get it again, so there's really not that much benefit in having it. And they cite the fact that it has been demonstrated that after about 3 months or 4 months, the antibodies that people that have had COVID, the antibodies that were circulating in their bloodstream are no more. So there is a time limit. So you don't keep the antibodies indefinitely. And so the media has presented that as evidence that everybody needs to be on guard and that even if you've had COVID, you can easily get it again. Well, that is wrong. Not only is that wrong, it proves that the perpetrators don't have any idea how immunity works. Your immunity to bacteria and fungi and viruses is not based on antibodies. Now, while that does help you, the antibodies are of help in terms of, if you go out and immediately are exposed to the virus again, certainly they are of benefit, and you can even give those antibodies to other people and it will help them fight COVID. So it's not that they don't work. It's just that that's not what gives you your long-term immunity. The statistics on reinfection are out there for everybody to see. As of October 2019, of all of the people in the United States that had COVID and survived, what percentage got it again? Or rather, how many got it again? We can use that data to calculate what the risk is. Well, as of October, there were approximately 11 million Americans that got COVID and fully recovered. Okay? How many of them got it again in the United States? The answer is out there. And the answer is 1. In the world, how many people have gotten COVID more than once? And that answer is known. In the whole world, as of October 2020, the answer is 5. 5 in the whole world. Out of all the millions of people that were infected with COVID and recovered, only 5 in the world got it again. So just looking at the American reinfection rate, that comes down to 1 in 11 million. So if you've had COVID, the statistics say that your chance of getting it again are about 1 in 11 million. Now, there are probably some cases of reinfection that didn't make the literature, so there might be a few more. However, the risk is incredibly, incredibly small. How is that possible? If we're not making antibodies long term, how in the world are these people protected? Well, it's basic immunology. When you have gone through an infection, whether it be viral, bacterial, fungal, or whatever, your T cells and your B cells have something called T memory and B memory cells. Those are subsets of your lymphocytes. And what that means is that these B cells, these B memory cells, if they see, let's say, a coronavirus again, then they remember exactly what coronavirus looks like. They remember what COVID-19 was built from, what the protein subunits were, what the spike proteins look like. And the B memory cells can very quickly turn into plasma cells or generate plasma cells, which make the antibodies specific for COVID-19. Okay? Now, if you don't have those memory cells, if you're exposed to COVID-19 for the first time, then there's a pretty long process that your body has to go through. Your macrophages have to eat cells that are infected with the virus. They break it down, and then you divide it up into sections. And so one clone of lymphocytes makes antibodies to one part of the organism. Another makes it to another part, and together, you have to literally. It's like you have to build a factory. And then that factory makes antibodies specific for your antigen, in this case, for your virus, for your coronavirus, okay? You've got to build a factory, and that's what takes time. So it takes a while for your body to adapt to a new infection. Once you're through the infection, though, the B memory cells, that's like your factory's already there. So as soon as you get exposed to it again, you no longer have to tool up. You no longer have to build a factory specific, because the factory exists and it's floating around just waiting for another whiff of COVID-19. Same thing with the memory T cells. They remember what antigens were expressed on cells that were infected with COVID-19. And so they are ready to attack. They can just, as soon as they see it, they remember, aha, I remember you. You're COVID-19. I've seen you before. And they immediately go into production of lymphocytes that are specific for COVID-19. That's called the adaptive immune response. And it's specific for that organism. So if you've got these memory cells floating in your blood because you've had a past infection, when you see that infection again, kabam, you jump all over that baby. And you don't have to wait very long at all to mount your response. Hence, these individuals have a very low likelihood of getting reinfected again. Okay? So that's one way to reduce the risk of having a severe coronavirus infection, is if you've had the infection and it was mild, well, you got protection. So the likelihood of getting it again of any type is very, very low. So that's probably the biggest way you can protect yourself. I don't recommend you go out and get yourself infected because, but if you have already had coronavirus, then having a mild case is really to your advantage. Now, the second one, take a COVID-19 vaccine, and that's coming up. Hopefully, it will be safe. We'll see. I hope that these vaccines are all safe and effective. The efficacy seems to be there, so we'll find out. But that's another way to mitigate the risk of having a severe coronavirus infection, is to have the vaccine. With the vaccines, they're looking at, out of 95 cases, you got that immunity, only 5 in 100 can still get coronavirus with the vaccine, according to the statistics that are floating around there right now. Number 3, melatonin. Now, for those of you who've watched my channel, you know that I have a whole program on melatonin, and I put this out way back in March, or I think it was March or April, okay? So I've been talking about this for a long, long time. When I developed COVID infection, I was taking melatonin, and that's probably why my symptoms were mild and over in about 4 days, okay? Melatonin boosts the innate immune system. Your immune system is divided into 2 big systems, the innate and the adaptive. The innate immune system, that is your military against microorganisms that is always on call. These are the guys that are there with their guns out, ready for any foreigner. And when a foreigner comes along, they're ready to shoot him. And the innate system isn't specific for all organisms, but it's kind of general. And so when it sees somebody that looks at them cross-eyed, they're like, you know what, I'm taking you out of here, boom, okay? That's your innate immune system. Now, your adaptive system, the adaptive system is something that is created in response to a previous infection. So let's say you were exposed to a particular strain of influenza XY, say, okay? Well, the next time influenza XY comes along, your adaptive response, because you already had to deal with that, okay? And you took, when you first got exposed to that XY virus, it took you maybe a week to build enough cells that are specific for that influenza XY, okay? But it took a while. You had to grow the cells, and these were cells that were specific for that virus, okay? Now, once you do that, though, and the virus is dead, if it ever shows up again, because you already went to the work of building those T cells and B cells, there are now memory cells there that remember what that influenza XY looked like. And so you're not going to get that again very easily because you have an adaptive response specifically for that agent. Now, having said that, and I'll come back to that later, if you bolster your innate immune response, you can reduce the likelihood that a virus will become severe, okay? Because if you attack it early on, it is so busy getting attacked, it doesn't have as much opportunity to make a bunch of babies. And so by the time it's got a population that can do you some harm, well, your adaptive immune response has been studying it the whole time. And now it's ready to fight. Okay? So if you can improve your innate immune response, you can reduce the likelihood of a severe infection. Melatonin helps you do that. Melatonin isn't just for sleep. It does a few things in your body. In your stomach, melatonin is produced by the enterochromaffin cells, and there it helps close the lower esophageal sphincter, which prevents gastroesophageal reflux. Okay? It also stimulates the immune system a lot. It's not just because it helps you sleep either. It stimulates your immune system directly. It enhances the production of immune cells, and it makes the immune cells that you do have more dangerous. Okay? So when you take melatonin, you beef up your innate immune response. That's your standing military. And so if you take melatonin early on with a viral illness, you will find that that viral illness is much less severe. Okay? And there is evidence that this works. This is a paper from November 12th, and they actually studied the use of melatonin in patients, and what they discovered when it comes to preventing coronavirus, COVID-19, they found that in African American populations, it reduced the likelihood of a positive lab test for COVID-19. It reduced it by 52%. In non-African American populations, it reduced the risk by 28%, almost 30%. Okay? So there is significant evidence that this does work, not just in general for viruses, but even for coronavirus. So I highly recommend the use of melatonin if you come in contact with somebody COVID or have any type of respiratory symptoms. Okay? So this is pretty impressive. All right?
Dr. Guy, we'll be taking a break when it is good, like if there's something that you want to wrap up first, but then after that, we'll be taking a break. Okay. All right, wonderful. So everyone, we are going to be taking a break. I do see some questions in the chat. I'll direct Dr. Guy to look at the chat to see if it's something that he wants to address after the break, or if it's something that he will just leave there, you know, some time at the end for the questions. So I do see the questions. I just want everyone to know that.